Good evening, everyone. At the outset, I would like to wish everyone a happy Doctor's Day on the behalf of Wincars. So today I'll talk about dyslipidemia. Now, based on the very old meta-analysis, very famous meta-analysis indeed, the cholesterol treatment trialist collaboration has shown already that a reduction of 1 millimole of per liter of the LDL leads to 12% reduction in all-cause of mortality, 23% reduction in heart attacks, coronary death, and a 24% reduction in coronary vascularization, and 17% reduction on fatal stroke. The apprehension, the very old apprehension about risk of developing diabetes, Jupiter trial already showed that rosuvastatin therapy can accelerate the time to new onset diabetes by only 5.5 weeks. That too in the people who already have underlying metabolic syndrome at baseline. So now coming to the management algorithms of dyslipidemia or secondary prevention of ASCVD. Now, when there's a clinical ASCVD, so obviously lifestyle modification is the first to follow. So we classify our patients to non-high risk and high risk ASCVD. If our patient is non-high risk and age is less than 75, then high intensity statin class 1. We can add ezetimibe if required. If patient is not less than 75, then high or moderate intensity statin class 2A indication. However, if patient is high risk ASCVD, for which we need to know the criteria when we define them as high risk ASCVD. So multiple major ASCVD events or one major ASCVD plus multiple high risk conditions. Major ASCVD events include recent ACS, history of MI, history of ischemic stroke, symptomatic PAD, and high risk conditions are age more than 65, heterozygous familial hypercholesterolemia, history of bypass or angioplasty, diabetes, hypertension, history of CHF, CKD stage 3 or more, current smoking, and persistent LDL, which we are not able to control. So, in these patients, obviously lifestyle modification has to be for both the pathways. But in these patients, we start with high intensity statin. We add ezetimibe. And if we achieve LDL more than 70 or non-SDL-C more than 100, then addition of PCSK9 inhibitor is class 2B indication. And if we can achieve LDL less than 70, then PCSK9 inhibitor is not required. FDA has approved PCSK9 inhibitors. They are two, alirocumab and evolocumab. Now, for population in which baseline LDL is more than 190, so we start with high risk, high intensity statin, class 1 indication. And in the population group where LDL cholesterol is not more than 190, we risk their assess by age. So we divide them into up to 19 years, 20 to 39, 40 to 75, and more than 75. For people obviously up to 19 years of age, familial hypercholesterolemia has to be considered. If they are having, then lifestyle modification goes first. If they are not having familial hypercholesterolemia, then also lifestyle modification will go class 1. And we check the response in 3 to 6 months. If no adequate response, that initiate statin. Class 2A. So this is, we are talking here of the population up to 19 years of age. If population is 20 to 39, then lifestyle modification, class 1. And if there's a family history of premature CAD or LDL more than 160, then we initiate a statin, class 2A. We assess the risk and we start high intensity statin. For people is 40 to 75, we see if one is diabetic or not. If patient is diabetic, then moderate intensity. If patient is not diabetic, then we calculate 30 years ASCVD risk percentage. So depending on less than 5, 5 to 7.5, less than 7.5 to less than 20, and more than 20. So accordingly, according to our this percentage of the score, we start with the lifestyle modification, moderate intensity if this score is less than 7.5. And if it is more than 20, then we start moderate or high intensity statin class 1 indication. So this is our guidelines we are following nowadays for secondary prevention of ASCVD. Now coming to optimal use of lipid lowering therapy in steps of acute coronary syndrome. So we know that when we see acute coronary syndrome patients, we load with them high intensity statin. That is our usual practice. Something more to it, because current guidelines are based on sound premise that with respect to LDLC, lower is better for longer period of time. And recent data have strongly emphasized the need is also earlier the better. So when we see a patient, when we diagnose a patient with ACS and we initiate for PCI, we have to consider these groups also, like heterozygous or homozygous familial hypercholesterolemia, extreme CV risk, and statin intolerance. If these things are not there, then we measure LDLC, and depending on whether this measured LDLC was on statin treatment or was without it, we decide next course of therapy. So suppose patient was getting statins, LDL less than 100, or patient was not on treatment, LDL less than somewhere 120, then we start with single lipid lowering therapy. Start with atorvastatin or rosuvastatin in statin naive patients and increase to maximum tolerated dose in current statin users. So we start these patients on maximally tolerated statin therapy. If patient is getting statins but LDL is 100 to 300 or without any prior treatment, statin LDL is 120 to 300, then we start from dual lipid lowering therapy. So we have to start ezetimibe right from the beginning. That is what the guidelines is. Now, if any patient during our ACS presentation also, if LDL is more than 300, we have to start triple lipid lowering therapy, that is maximally tolerated statin therapy or ezetimibe and PCSK9. Provide them discharge summary outlining plans for immediate treatment and escalation. Monitor lipids for after 4 to 6 weeks. And if we achieve LDL less than 55 because the ACS situation, then follow up. And if no, then further intensify therapy in the form of whatever is left. Now coming to special pathways. These special pathways, about this special pathways I am talking when patient comes to us in ACS and we are considering PCI. So these are the special cases wherein we have to consider it differently. So special pathways are which ones? Wherein patient is having recurrent MI plus previous vascular event in last 2 years, or ACS plus multivascular disease, or ACS plus polyvascular disease, or ACS plus familial hypercholesterolemia, or ACS plus diabetes plus at least one additional risk factor. In these cases, we have to consider immediate initiation of dual lipid lowering therapy and intensify if necessary. So triple therapy, as we discussed already, maximum tolerated statin, ezetimibe and PCSK, and monitor lipid after 4 to 6 weeks. If LDL less than 40, then yes, follow up at 3 months. If no, then intensify therapy. Maximally tolerated statin, ezetimibe and PCSK. So this is something which we have to, I think, bring into practice more often now. Patients already taking statin therapy and ezetimibe for at least 8 weeks prior to admission. Statin therapy should be intensified if possible, and immediate treatment with PCSK9 inhibitor should be considered. Now, for the population wherein people are already, they have shown that complete statin intolerance they have. So we initiate with ezetimibe monotherapy and intensify if necessary. So single LLT, ezetimibe, and if we need to intensify, then we have to add PCSK9 inhibitor. Provide discharge summary outlining plans for immediate treatment escalation. and monitor lipids. If LDL less than 55, then follow-up 3 months. If no, then dual LLT, ezetimibe, PCSK9 inhibitor. For the group, the patients who are already on high-intensity statin therapy plus ezetimibe for at least 8 to 12 weeks, and LDL is still more than 120, then intensify maximally tolerated dose if we have an option or scope, and consider immediate PCSK9 inhibitor in hospital setting. Monitor lipids after 4 to 6 weeks. If we reach LDL less than 55 is good. If no, then further intensify therapy. Monitor lipids after 4 to 6 weeks and LDL less than 55 and follow up at 3 months. Otherwise, intensify the therapy. Now, this is a line about Odyssey trial. Evaluation of cardiovascular outcomes after an acute coronary syndrome during treatment with alirocumab. So we all know Odyssey trial. 18,000 patients were studied with ACS in previous 1 to 12 months. They were randomized to alirocumab versus placebo. And what was seen was a reduction in LDL-C of 62.7%, 61%, and 54% at a 4, 12, and 48 months respectively. The primary endpoint of cardiovascular death, non-fatal MI, non-fatal stroke, hospitalization for unstable angina, occurred in 9.5% in the alirocumab group and 11% placebo group. And all-cause mortality was 17% lower in alirocumab. Now coming to next molecule, which we have now, inclisiran. Inclisiran therapy is a novel approach to LDL-C lowering. It's a small synthetic interfering RNA. Its target is messenger RNA for PCSK9. And within the intracellular milieu, inclisiran binds to the RNA-induced silencing complex RASC, allowing endonucleases to hydrolyze PCSK9 messenger RNA, thereby inhibiting its expression. Further advantage of inclisiran is that, as opposed to PCSK9 antibody injections, which are given every 2 to 4 weeks, it has shown effect when given just twice annually. Coming to next molecule, bempedoic acid, which is already in the market, and I'm sure many of us have started using it. It's a novel LDL-C lowering agent and inhibits cholesterol synthesis pathway at the level of ATP cyclase, which acts upstream from HMG coenzyme reductase and is an enzyme that integrates lipid and carbohydrate metabolism. So if we see this, our very famous diagram, wherein HMG coenzyme inhibitor and the pathway where statin works. So this is upstream of statin pathway. Now coming to its indication, it is already approved in countries like USA, India, Europe, in 2020 in US and Europe. For the indications, for reduce uncontrolled LDL-C with maximum tolerated statin dose, mixed dyslipidemia, familial hypercholesterolemia, high risk of ASCVD patients, statin intolerance or whom statin is contraindicated. Dose is 180 milligram orally with or without food. It is first-in-class agent having unique mechanism of action of ACL inhibitor, significant LDL reduction up to 18% from baseline as an adjuvant to statin, safe in mild to moderate CKD patients. Hyperuricemia and gout are common adverse events which should be monitored on a regular basis. Now, if we see these combining lipid therapy as first-line strategy in a very high-risk patient viewpoint, so they have already considered bempedoic acid. So if we just go through cardiovascular risk assessment, very high risk, extremely high risk. Start with the statin ezetimibe. If less than reduction 50% or LDL more than 1.4 millimole, then add PCSK9 targeted therapy or bempedoic acid. So obviously now naturally we can consider bempedoic when we cannot or we need not to be PCSK9. Now coming to next very common topic rather and little less, slightly less discussed, I must say, how to diagnose familial hypercholesterolemia in clinical practice. So Dutch Lipid Clinical Network Diagnostic Criteria for familial hypercholesterolemia we follow mostly. And criteria is, we see family history. First degree relative of premature, we know the definition of premature. First degree relative with LDL more than 90 percentile. Or first degree relative with tendinous xanthomas and or arcus cornealis. For children less than 18 years of age with LDL about 95% of percentile. So we give 1 point to this and 2 points to this. Patients with premature history, 2 points. And with premature cerebral or peripheral vascular disease are given 1 point. Tendinous xanthoma 6 points, and arcus cornealis before the age of 45, which we need to see cornea, 4 points. And LDL level, if more than 325, state 8 points. 251 to 325, 5 points. 191 to 253 points, and 150 to 190, 1 point. Functional mutation, if we can establish, 8 points straight away. And a definite familial hypercholesterolemia requires more than 8 points. Probable 6 to 8 points, and possible requires 3 to 5 points. So this is how we diagnose familial hypercholesterolemia. Now, detection and treatment of patients with heterozygous familial hypercholesterolemia, we know that it is not that uncommon. In fact, incidence is almost 1 in 500. So FH is recommended to be suspected in patients with CHD before the age of 55 years for men and 60 for women, in subjects with relatives with premature fatal or non-fatal CVD, in subjects with relatives having tendon xanthomas, and in subjects with severely elevated LDL-C, that is 190, in children more than 150. So in these subsets, we should suspect heterozygous familial hypercholesterolemia. Diagnosis is recommended to be confirmed with clinical criteria, and if available, obviously DNA analysis is the best thing to do. Family cascade screening is recommended when an index case of FH is diagnosed. And FH patients are recommended to be treated with intense dose statin, often in combination with ezetimibe, and all of them, they are class 1 indication. So that is how treatment with PCSK9 antibody should be considered in FH with CVD or with other risk factors, putting them at very high risk. Family history, high LPR statin intolerance. Now, talking about next molecule, mipomersen is an antisense oligonucleotide that binds to messenger RNA for ApoB and promotes hydrolysis. It is indicated for the treatment of homozygous familial hypercholesterolemia, which is obviously rare, but it's fatal. And its efficacy is mechanistically independent of LDLR bioavailability. A group of 124 patients with homozygous FH randomized to weekly mipomersen versus placebo exhibited very similar results with a mean LDL reduction of 28% in mipomersen arm versus 5.2 in mean LDL participants receiving placebo. While the drug has been approved by US FDA for the treatment of homozygous FH, neither US nor European guidelines recommended it as a therapeutic option at this point of time. It should be used only when within the context of a risk evaluation and mitigation strategy intended to reduce risk for hepatotoxicity. Now, talking about next molecule, lomitapide is a small molecule inhibitor of microsomal triglyceride transfer protein, an enzyme in the endoplasmic reticulum important for the production of VLDL-C in liver and chylomicrons by enterocyte because it lipidates ApoB100 and ApoB48 respectively. So it reduces plasma levels of ApoB containing lipoproteins, including VLDL and LDL-C. Next molecule available is elvinacumab, is a monoclonal antibody directed against angiopoietin-like 3, an enzyme that inhibits both endothelial lipase and lipoprotein lipase, and is recently approved by FDA for the treatment of homozygous FH. So data from elvinacumab lipid studies in patients with homozygous FH showed that in 65 patients randomized to intravenous elvinacumab versus placebo. This monoclonal antibody reduced a 49% mean between group difference in LDL at 24 weeks. Subsequent work has shown subcutaneous administration of ivanicumab similarly effective, with a 56% between group difference in LDL-C reduction between ivanicumab or 50 milligram versus placebo. So these changes in LDL-C are attributed to increased clearance of LDL particles by hepatic remnant of lipoprotein receptors. Much recent data have supported elevated triglycerides as an independent risk factor for ASCVD, because of late we were focusing more and more on LDL, but yes, triglyceride is also not something which we should forget so easily. So we have to keep that also in mind. In post-hoc analysis of pravastatin or atorvastatin evaluation and infection therapy, that is PRO-TIMI-22 trial, low triglyceride level in 4,000 patients with recent ACS were associated with a reduced rate of recurrent cardiac events, irrespective of attained LDL-C level. And among participants in the study of RO4607381 in stable CSD with recent ACS and myocardial ischemia reduction with aggressive cholesterol lowering cohorts, triglycerides level correlated with both short and long-term cardiovascular risk. In a cohort of 29,000 participants, the Copenhagen general population study showed not only increased risk in association with elevated triglycerides, but also showed that on a per particle basis, VLDL was more atherogenic than alternative ApoB containing lipoprotein such as IDL or LDL. Now coming to the topic of our forum, that is primary prevention of cardiovascular disease in women. What is different? What is new? So talking about statins for ASCVD prevention in women, yes, in this subset we should give like secondary prevention of clinical ASCVD, we should give. Primary hyperlipidemia, wherein LDL more than 190, we should give. For people who are diabetic, they should receive. And for primary prevention of age 40 to 75 years, in cases of high risk, that is more than 20 score, or intermediate more than 7.5 to less than 20 with risk enhancers. And risk enhancers are premature menopause and pregnancy-associated conditions that increase ASCVD risk. When we should not give? For primary prevention of females 40 to 75 at low risk, when they're pregnant and when they're intending to get pregnant in next 1 to 2 months. We may think to give, or we may decide at our individual level. For primary prevention, when age is 40 to 75, and patients are borderline risk 5 to 70, less than 7.5, with risk enhancers. If clinician-patient risk discussion favors statin, then we can start. Now coming to a very interesting molecule, that is LPA. LPA was discovered in human serum in 1963 by Karreberg during a study of variation LDL antigenicity. Further characterization of LPA showed it to be consisting of an LDL covalently bound to a unique protein called ApoA. Now, what is lipoprotein A in clinical practice? It's a promising biomarker to help refine current strategies of ASCVD risk assessment, and it is estimated to be elevated in approximately 20% of the world's population. So a markedly significant number. Research on LPA suggests it has added value in preventive medicine, and it is time for cardiologists and cardiovascular team members to consider using it routinely in their practice. Based on the mounting evidence, Wilson et al. Recently published a guideline on the clinical use of LPA from National Lipid Association. An individual's LPA level is 80 to 90% genetically determined in an autosomal dominant inheritance pattern, with full expression by 1 to 2 years of age and adult-like levels achieved by approximately 5 years of age. Outside of the acute inflammatory state, the LPA level remains stable through an individual's lifetime, regardless of lifestyle. So that is something which we have to consider despite whatever efforts our patients are taking for the lifestyle modifications. Now, what is the amount of increased risk between highest and lowest LPA concentration for MI? And these associations have been supported by Mendelian randomized studies. All of them are yes. MI 3 to 4-fold, valvular AS 3-fold, coronary artery disease 5-fold, carotid 1.7-fold, ischemic 1.6, femoral artery 1.6. So we can see that all cardiac, cerebral, and peripheral artery disease spectrum, it is having its role. So much so all-cause mortality 1.2-fold, and heart failure also 1.5 to 2-fold. So this is impact of elevated LPA levels on various clinical outcomes based on large prospective population-based studies. Now, this is the population subset when it is reasonable to measure LPA at least once in lifetime based on current evidence. For primary prevention, when first degree relatives with premature SCVD, that is less than 55 for men and less than 65 for women, particularly in absence of traditional risk factors. So we must assess our patients' LPA at least once in their lifetime for primary prevention as well. Primary severe hypercholesterolemia, wherein LDL more than 190 or suspected FH. To aid in clinical patient discussion about statin initiation in age 40 to 75 with borderline risk also, that is 5 to 7.4. So this is certainly a new molecule at horizon, which we should at least once in our patients with these defined criteria should measure. Cascade screening of family members with severe hypercholesterolemia, risk enhancing factors and discussion about statin therapy for immediate 10 years risk. For secondary prevention, personal history of premature ASCVD, recurrent or progressive ASCVD despite optimal lipid lowering therapy, ischemic stroke less than 55, and FH with ASCVD. To identify possible cause for a less than anticipated LDL lowering to evidence-based LDL-C lowering therapy, identify those at risk for progressive valvular aortic stenosis. Now, this is a study done by all of us in our department only, and it was published in Atherosclerosis Journal. So we concluded that it was higher in young CAD, and patients with elevated LPA exhibited severe disease angiographically. The results suggest that LPA levels more than 50 milligram per deciliter seems to be useful in identifying high-risk young individuals. Now, ACC 2022, silence takes on Novartis and Amgen. A couple of years ago, the small interfering RNA specialist Silence Therapeutics refocused efforts on SLN360, project designed to decrease LPA in cardiovascular disease. Now the company has promising early data. It could compete against the likes of Novartis and Amgen. The phase 1 Apollo study presented ACC this time, and they found that a single 300 milligram or 600 milligram dose of SLN360 decreased LPA levels by 70% and 81% respectively at 5 months. So with the usual caveats about cross-trial comparisons, this looks about in line with the regular dosing of the field's leader, Novartis pelacarsen, in phase 2, the highest dose of the latter, 60 milligram monthly or 20 milligram weekly, which reduced LPA by 72% and 80% respectively at 6 months. Novartis is testing an 80 milligram monthly dose in its pivotal LPA Horizon trial, of which our department has been a part of. One patient in Apollo receiving a 30 milligram dose of SLN360 had liver enzyme elevations, but the most common adverse events were injection side effects. Phase 2 is due to start later this year. If silencing can keep up the performance, it could have a contender on its hand. So projects in clinical development are getting apolipoprotein A, pelacarsen, olpasiran, SLN360. Effects of pelicarsen on LPA and corrected LDL cholesterol. So baseline LPA-C values raised from 11.9 to 15.6 milligram per deciliter. LDL correction was approximately 13 to 16 lower than the laboratory reported LDL-C. And pelicarsen significantly reduced LPL-C by mean 29 to 67% in dose-dependent manner, compared with a mean decrease of 2% in pooled placebo. It was associated with a mean percent decrease in laboratory reported LDL-C. So to come to a perspective of it, LPA is now accepted as an independent risk factor for cardiovascular disease and is a target for new therapies such as pelicarsen. Decisions regarding choice and titration of these therapies rely on an understanding of the relative contribution of LPA-C to lab-reported LDL-C in patients with elevated LPA. And this study shows that lab-reported LDL-C is incorrectly reported as higher than the corrected LDL-C in patients with elevated LPA. So measuring both LDL-C and LPA-C may allow for a better personalized approach to determine severe risk using a corrected LDL-C. So to conclude my talk, certainly our understanding of lipid disorder has gained tremendous movement, and we shall be better equipped to deal with menace of dyslipidemia in coming future. Thank you so much.